This video continues Chapter 15 of OEC 6 by looking at cardiovascular emergencies, and specifically the assessment of a patient with a cardiovascular emergency. We want to look specifically at how to assess and treat this patient, and consider again some of the signs and symptoms for these cardiovascular disorders. As with all assessment, the most important thing is to begin by ensuring that the scene is safe, and then moving into a primary patient assessment where we deal with life threats, any problems related to ABCDs. Now, if a patient is unresponsive, not breathing, and pulseless, our algorithm changes from ABC, following Heart Association or Red Cross guidelines, into CAB, deal with this cardiac event, this circulation life threat, and immediately begin CPR and call for an AED and ALS. Do not delay transport except to use the AED. If you're able to move then to patient history and secondary assessment, pay very close attention to any complaints of chest pain, and in your sample history, any cardiac medications such as nitroglycerin or a daily aspirin. If they took nitroglycerin, ask if the symptoms they're experiencing have gone away, diminished, or stayed the same. You can think of it as that kind of P, provocation or palliation, in our OPQRST algorithm. If the patient has difficulty communicating, find a relative or a friend as a bystander who can assist this with you. Now, some of these medications may not be familiar to you. We have different things like Lopressor, which lowers blood pressure because it's a diuretic. The nitroglycerin is specifically a vasodilator and can deal with the effects of an AMI by opening up coronary arteries. Daily aspirin will help prevent clot formation and assist with that as well. Lasix is another diuretic that we find. One thing to possibly remember is a lot of heart medications will have this OL as a suffix, and if not sure, ask what is that medication, and more specifically, why do they take it? Ask a family member if needed. Now, continuing with that OPQRST mnemonic, one of the things we consider in addition to onset or provocation or palliation is the quality of the pain. Is it heavy? Is it crushing? Is it tight? Does it feel like an elephant is sitting on their chest? Chest pain is less commonly described as being sharp. It's also important to consider the R part of our mnemonic. Does that pain radiate into the jaw or abdomen or down the left arm? Referred pain is a common symptom that is reported in the case of a myocardial infarction. We look here at possible ideas of pain. Pain being just under the sternum and thought of as heavy pressure on the chest could be a possible sign or symptom of that myocardial infarction. Here we see the idea of radiation, specifically in this case down the left arm as well, or radiation into the neck and the jaw. Consider all of those as you work through the OPQRST mnemonic. Now, a unique characteristic of an aortic dissection is to describe the pain as tearing or as acute severe back pain. We want to be sure also whether the pain or symptoms improve with rest or remain constant. That's the P for palliation in OPQRST. And also part of our sample history, we might want to consider not just drugs that the patient might be on because of a pertinent health history of some cardiovascular disease, but illicit drugs that could increase the risk for an acute myocardial infarction. We see stimulants such as cocaine or meth contributing to this. Moving to the secondary part of our assessment and a physical exam and vital signs, we may notice that they're short of breath and correspondingly have an elevated rate of respiration. Check pulses and capillary refill, and look for evidence of tissue perfusion, such as capillary refill looking for pink under the nail beds alongside skin color and temperature. If you see profuse sweating, sometimes we refer to the patient's appearance as being PCC, pale, cool, and clammy, rather than the healthier PWD, pink, warm, and dry. This may be a sign that the anxiety and some of those other things, or possibly on their way to shock with an AMI, this is critical to note. Reassess the patient and the vital signs at regular intervals, every 5 minutes if the patient is unstable, 15 minutes if the patient is stable. Record the vital signs and pay attention to the trend, in particular if the trend in vital signs is deteriorating. Never delay transport for a patient who's having a cardiovascular emergency. Call for that transport early, and if appropriate, make sure that all of the resources you need, such as an AED, are available. Now, for a patient experiencing hypertension, some of these symptoms and signs do not become apparent until the blood pressure reaches crazy high levels. Now, that's going to vary from person to person. Some of those symptoms and signs could be headache or vision disturbances, or even seizures, nausea and vomiting, and then bounding pulse. Dangerous levels of hypertension will have associated chest pain and shortness of breath as well. In the case of angina or myocardial infarction, remember the cause is not enough oxygen getting to the heart muscle. They'll present with similar signs and symptoms. They may describe, again, the pain, and it may be only in the chest, but it may include that radiation as well. Other signs and symptoms, the anxiety, nausea, diaphoresis or sweating, and along with that anxiety, feelings of impending doom or death. Women may present atypically. Now, there can be a heart attack without chest pain. This happens in up to 1/3 of all cases, but it's more common in women or diabetics. Some of the other symptoms will still be in place, such as shortness of breath or fatigue, but we might get more referred pain to the upper back or the abdomen. Patients in cardiogenic shock will have a deathly ill appearance, such as pale skin, sweating, and anxiety, and obvious respiratory distress. Now, the cause of that cardiogenic shock, a problem with the pump, could be, again, an acute myocardial infarction, in which there'll be tachycardia, a very high heart rate, but then also a very low blood pressure. If the cause of the shock is an abnormal heart rhythm, we'll still see low blood pressure and possibly tachycardia, but possibly bradycardia as well. For the patient in congestive heart failure, there's a wide range of signs and symptoms, and it depends on which side of the heart is affected. Right-sided CHF is that congestive heart failure in which the right side of the heart, trying to move blood returning from the body to the lungs, is failing, and consequently, because we get a backup of blood in the body, we're unable to effectively move it to the lungs, we're going to see things like swollen ankles and so on. The more pronounced the swelling, the more the more severe the CHF is. Now on the left side, think about it, we're bringing oxygenated blood from the lungs into the left atrium and then out the left ventricle to the body. So the backup is actually going to be a backup to the lungs. Blood trying to enter the left atrium is unable to continue its movement through the left ventricle and then exiting to the rest of the body. So if we get a backup there, the backup is going to get traced back to where the lungs are. Consequently, what we'll see is fluid building up in the lungs, and we might hear that if we auscultate the lungs with audible bubbling sounds. Now, patients can have congestive heart failure on both sides at the same time. For pericardial tamponade, that buildup of fluid in the sac surrounding the heart, pericardium, we'll see hypotension, which is abnormally low blood pressure, and then a response to a problem with the pump, a response to poor perfusion, shortness of breath, pale, cool, and clammy skin, and an elevated heart rate. Along with that, we can also see distended neck veins. The veins are trying to return blood to the heart, but we end up with distension because the heart is unable to, for lack of a better term, accept that blood and then move it effectively to the lungs to complete its round trip. Other signs will be a pulse pressure narrowing. That is, the systolic, which is the top number, and the diastolic, the bottom number of the blood pressure, get closer. The systolic pressure is lowered, and that's why the gap gets narrower. The left ventricle is ineffective in forcing blood out when the heart contracts, and consequently, the systolic pressure, the pressure measured as the heart contracts, is lower. Why? Because fluid in the pericardium is limiting its ability to fill. The diastolic pressure is going to get higher because of pressure building up even when the heart is in its relaxed phase. So ordinarily, let's imagine a patient who is 120/60. We're going to see the systolic number drop and the diastolic number elevate, and the gap between them, the pulse pressure, will narrow. A thoracic aortic dissection is going to be accompanied oftentimes by back pain, and specifically may be described by the patient as a tearing sort of a pain. Now, unless the dissection has ruptured, they're going to have an extremely high blood pressure as a result. Rupture of the thoracic aorta can result when a person has a rapid deceleration, if they hit a fixed object with their chest when they're moving rapidly. Aortic aneurysms may present in the older age group, and if you suspect an aortic aneurysm is possible, do not perform an abdominal exam and put pressure on any of the quadrants. Because you've got this bulging in the aorta, pressure during your exam could lead to a possible rupture. Once that ruptures, the patient is going to go into profound shock, rapid drop of blood pressure, and they're at great risk for dying. Pulmonary embolisms, remember, this is a clot that has traveled to the lungs, are going to be presented as a sudden onset of chest pain and shortness of breath. Tachycardia will also accompany this because of essentially they're moving into a shocky situation. They're hypoxic and they have poor perfusion. The pain is described as sharp and will increase with deep breaths. Cyanosis is possible again because they're hypoxic. Now, if a patient is suspected of having a pulmonary embolism, a good sample history will help you uncover this. Signs and symptoms of DVT, where they have a deep vein thrombosis that could have been the cause for the embolism. The clot can form in the leg and then eventually travel to the lungs. Look for that presence, and it may not be some of these specific signs and symptoms that we see, but a good patient history. If you discover that they were perhaps on a long airplane or car ride recently and allowed that clot to form, is essential to uncover. While finding a DVT will not affect the acute management, dealing with what's potentially a life threat, it can help as you make handoff to higher care.